okay with it being recorded, your talk?
Sorry?
Are you okay with your talk being recorded?
Yeah, of course. Yeah, definitely.
Interestingly, we saw 3 Titans yesterday.
Seriously.
Yeah, it was a weird day.
Did they do an EMG on one of them?
On one of them, yes.
Yes, I remember
The rest
that.
we have sent your way.
Okay, good. I think there's
Yeah.
someone follow. There was one recently, I think, was it today or yesterday? Yesterday. Nothing. I couldn't find anything though. I did single fiber as well. It was a older child, 11-year-old. I think full exome was negative. Oh God, I can't remember now. Congenital myopathy.
Oh, hi, Dr. Urvi. Dr. Urvi is there as well. Joining from the middle of our OPD in the US. Early morning time, I mean mid-morning OPD time. Thank you, Dr. Urvi. She's our adult neurologist.
Hey, how are you? I'm going to join, but I'll be I'm going to join, but I'll be in and out of the clinic. So,
Sure.
but I really love the topic that you have chosen. So thanks, Anne.
Yeah, I thought it was more adult. So we were thinking about for the next time more imaging, neuroimaging.
Awesome. Is it muscle MRI you're thinking?
Yeah, quantitative and semi-quantitative, the T1, T2 fraction, and
Nice.
how, yeah, and along with ultrasound.
Who's doing that talk?
Right now, I don't have anybody, which means Dr.
Can you-
Pawan and me.
Or, can you reach out to Dr. Erd? Dr. Erd? He had given
Short notice. Next
short notice. We can give him another month if he would do that.
Okay.
Yeah, he gave a really good talk on muscle MRI a year ago. I went to a neuromuscular colloquium, and he really focuses on that. So
I will ask but I'm not sure it'll work.
no harm in asking.
No harm in asking. Do you have his email address?
I will look into that.
Isn't he in Europe somewhere?
He is in
Norway.
no, some Eastern Europe, like Romania or something like that. But I'll look into that.
Okay. Do you know him personally?
No, but
okay.
nothing wrong in asking.
Okay. Okay. No, because
and then Jody at Newcastle. Hold on one second. Sorry.
So Professor Mercury said he would do one.
Hello.
Hey, your next one's ready in 177.
Okay, thanks.
Yep.
Professor Eugenio Mercury said he would do one for us.
Okay.
But that would be later on. This would be just a beginner prelude, which we thought we'll do, basic.
Okay. I mean, yeah.
On quantitative, and then get the big cheese later.
Yeah.
Okay.
You are in the game of getting the big guns, so I think it's all good.
So Dr. Pawan, who's here, is going to be doing the talking.
Nice.
No, Dr. Pawan?
Do I?
You know Dr. Pawan. He works with me. He's my colleague.
Oh yes, he is going to do the talk today. Oh, wonderful.
Not today.
Hi,
Not today. Next month. Next month.
Okay.
He's not showing his face.
Okay. All right. I'm going to step out and then join again. Sorry, I have to go for this patient. So.
Sure. We're just a few minutes over, and there's a few people who join in. I will step back. I'll just say thank you, Dr. Sumant, for agreeing to chair the session. And I'll leave the stage to you. But after expressing a big thank you to Organization for Rare Diseases India, who just conducted their 9th year in a running Race for 7 in fundraising and creating awareness for rare diseases. On to you, Dr. Sumant, and the speakers for the day. Thank you.
Yeah, good evening, everyone, and thank you, Dr. Ann, for asking me to moderate this session. So we have 2 talks by neurologists and clinical neurophysiologists, mostly focusing on anterior horn cell disease. The first talk is by Dr. Bhuvaneshwari Rajendran, who's a neurophysiologist based at Kaveri Hospital in Chennai. And she's going to talk on motor neuropathy versus motor neuronopathy, designed to distinguish. Over to you, Dr. Bhuvaneshwari.
Hi, good evening, everybody, and thank you all for giving me this opportunity. A big thanks to Anne for actually organizing this meeting every month on month, and inviting me for this month's talk. So let me start sharing my slides. Are you able to see?
Yeah, we can see.
Okay. So today my talk is focused on what is the design or protocol that you would follow when you want to distinguish neuronopathy from a neuropathy. See, many a times you would have a case, say for example, a wrist drop presenting to you in the clinic, and you want to identify the problem and also localize the lesion. So when somebody presents with a wrist drop, isolated wrist drop, the problem could be the nerve, it could be the plexus, it could be the root, it could be the anterior one, sometimes even central. A small lacunar infarct in the precentral gyrus can just present as an isolated wrist drop. So we have to be extremely open-minded, at the same time diligent in following certain steps to make sure that you identify the lesion correctly. So that is what this talk is going to focus about. And to illustrate what I'm saying, I have a few case reports which will highlight the exact points that I just mentioned right now. So the first case is a 32-year-old gentleman who presented with a history of right foot drop. He is an office worker, so sitting for long hours. After one long session at work, he developed some pain around the knee and pain over the lateral side of the foot. And then after that, the next day, he was not able to walk very well. He had the foot drop. Otherwise, is a healthy individual, no background medical problems or any habits. So clinical examination, he was walking with a clear foot drop, and there was weakness of the ankle dorsiflexion, power of 3/5, and plantar flexion was essentially normal. There was some hyperesthesia.
Ma'am, hi. Can I interrupt you, ma'am? I think the PPT is not in slideshow. We are not able to.
You're not able to see the slides?
Yeah, I think it's actually starting from the 4th slide, I think, of the PPT, and it's not in slideshow. I think you need to go to slideshow.
I am from the slide. I am showing the slideshow. So
I
I am
don't
on the
know what
4th
the
slide
other.
right now.
Yeah, it's not in slideshow as far as I can see.
Okay,
It was
let's.
not on a slideshow for us. Also, it wasn't moving. The slides weren't moving for us.
It's
Yeah,
not.
the
It's
slides were.
moving now.
Yeah, it moved now. It's in the 3rd one now, but it's still not in slideshow.
Oh.
When you shared it, did you share it from Windows screen?
Yeah, it was shared on the Windows. Let me
On the
see.
Windows, yeah.
Try again. Let me try again.
Yeah.
Okay. Windows share. So you're able to see what I'm clicking right now?
Yeah, we can, but it's still not in slideshow. It's moving.
No, I'm
but
going to slideshow. I'm now clicking on slideshow. I'll say beginning, and then is it moving?
No,
Hello?
ma'am, it's not.
It's not moving.
It's not moving. It's
Oh.
now. Yeah, now we are in the 2nd slide.
Are you seeing case 1?
Yes, ma'am. We're seeing case 1.
You're seeing case 1, right?
Yes.
And are you seeing the second one, walked with a clear foot drop?
No.
No, Bhuvna, actually, we're seeing case 1, but we're not able to see them in slideshow. I mean, we're just seeing it next to each other.
On my screen, it says slideshow. I don't know why it's not presenting itself as slideshow for you guys.
Okay. Not sure myself. When you shared it, what were the options for sharing? The entire screen.
You mean the problem is there are videos. So are you seeing the 3rd slide now?
Yes.
Yeah. Yes.
Okay, I think we'll have to go to the basic and click on each one and then show the thing. I don't know. It's not
Sure,
moving.
yeah.
Because for
Yeah,
me, it says slideshow, but for you guys, you're not seeing it as slideshow. I don't know why. It's a bit odd. Okay.
Yeah, I mean, we can see the slides clearly, but I guess you can carry on.
Okay. When it comes to videos, I will just enlarge that and put it on slideshow and then show you the videos. Okay.
Sure, ma'am.
Okay. I think that's what I'm going to do. Okay. So, as I said, he had a foot drop and he had some sensory symptoms as well. And when we did the neurophysiology, are you able to see these slides well? You can see the conduction block across the knee. So this is when you're stimulating at just above the ankle. This is at the fibular head, and this is in the popliteal fossa. So you can see the drop in the amplitude when we come to the fibular head. And correspondingly, the superficial peroneal, which is the sensory fiber of the peroneal nerve, you see that being absent. Now, this is very, very important when you're doing a neurophysiological study. What are the motor responses like? And what is the corresponding sensory response like? Because if you get your sensory, then and if your motor responses are affected, then it immediately, as a neurophysiologist, you're thinking preganglionic, or something muscle, or it's not just a peripheral nerve or an entrapment. So that is very, very important. So the first step when you're doing your neurophysiological examination is to look for the sensory fibers. As you can see in this, you can see a clear conduction block, very good. So that shows there is entrapment across the knee, and absence of superficial peroneal. So it's a postganglionic uh, neurogenic insult. And with the history, you're dealing with a common peroneal nerve palsy, an entrapment at the fibula head. That's very straightforward. Then let's go to the second case. Now, the second case, again, a young 32-year-old with a history of right foot drop. He's an office worker, and he's also a regular runner. He's been having some nagging low back pain for some time. Otherwise, a very healthy individual. And we go on to do our nerve conduction study. Here I'm trying to, if you look at the two boxes here, this is on the left, and you can see the responses are well preserved, the motor responses, peroneal motor responses. So ankle, your fibula head, and your popliteal fossa. They are all well preserved. There is no drop in the amplitude. Whereas on the right side, you can see that there is a drop in the amplitude at the fibula head, and more so as you come up to the popliteal fossa. So there is a drop, but the conduction block is not as prominent or more than 50% like what you saw in the other individual. And if you compare it with the other side, with the left side, clearly there is an asymmetry. On the right, it is being smaller. Now you go to, as I said, the sensories. Now the sensories here is well preserved. As I mentioned earlier, for me, when I see a small motor response and the corresponding sensory fiber being preserved in a clinical scenario such as this, I'm thinking, am I dealing with a preganglionic region, like especially with a low back pain? Are we dealing with an L5 radiculopathy? And that's exactly what the gentleman had. He had an L5 radiculopathy, which was presenting itself as a foot drop, and the neurophysiology was able to match. We were able to correlate the clinical features with the neurophysiology and with the imaging. So that was a very satisfying case. Okay, so now we've seen neuropathy, we've seen a root lesion. Now we have a third case scenario. You have a young 32-year-old with a right foot drop. So he, after a very long session at work, he developed some pain around the knee and then pain over the lateral side of the foot. And the very next day, he started walking with a right foot drop. He's otherwise a very healthy individual. So you have examined him, and then you're asking him more questions. So, and the question he sees when you start questioning him, he says sometimes he gets numbness in his hands, and he also gets a crampy pain in his hands, right more than left, which sometimes wakes him up from sleep. And further questioning, he says, as a child, when he was playing cricket, he had left-sided foot weakness, which recovered within 24 hours. So he didn't even consult a doctor. So in this situation, can I just invite some people to just tell me what I could be dealing with here?
HNPP?
Hello?
HNPP?
Yes. So as we did, apart from the peroneal motor responses, when we did his upper limb studies, there was clearly bilateral median nerve lesions. And sometimes in HNPP, you will also see that the sural responses could be absent. In some patients, sural responses are preserved. So it is very important not just to go with sural responses. You have to look at the history, and you have to show that there has been on and off fluctuating weakness in this person with the history, as well as and recovery in the past. So that will give you a clue that you're dealing with HNPP. As you all know, HNPP is associated with the novel deletion of PM22 in about 80% of the cases. It is autosomal dominant, but you must also remember it could also be a de novo mutation causing HNPP like presentation. Doesn't have to be following the Mendelian transmission all the time. Okay, now next case scenario. We have a 54-year-old. So we've now moved on to a middle-aged guy. He's presented with a history of left upper limb weakness, distal more than proximal muscles for more than a year now. And last few months, he's also noticed that he's having a right foot drop while walking. He's a very active man, no major sensory symptoms, no pain, both in his upper limbs as well as now with the foot drop. On examination, you can clearly see that the left first dorsal interosseous muscle is kind of thinned out. His hand grip was weak. And further testing his reflexes, his left triceps jerk reflex as well as the right knee jerk was slightly depressed. But rest of the tendon reflexes were within normal limits. Plantars were downgoing. No bulbar symptoms or signs. We now do the neurophysiology, and we find that when you're doing the nerve test, median, you've actually stimulated at the wrist, at the elbow, then you've gone on to the axilla, and then you go on to the Erb's point, you see a clear drop. And this drop is more than 50%. It's quite a significant drop. And whereas it is not so with the sensory fibers. The sensory fibers are all well preserved. So again, the sensories are extremely helpful because now you're dealing with something very motor focused, either a motor neuropathy or a neuronopathy. But here, before you reach the radical or the root, you've seen the foot drop. So somewhere in the Erb's point or near the plexus. So it is a proximal stimulation that has actually brought out this conduction block. Now, as I said, this conduction block is more than 50%. It is outside the entrapment points with normal sensory responses. And here we are dealing with multifocal motor neuropathy with conduction blocks. Now, many a times it is not so easy. You will have the history, but actually demonstrating the conduction block is not easy. Even when you do a proximal stimulation, it will not bring out the conduction block as we expect. And many times when we are trying to demonstrate a conduction block, certain tips that you can follow to bring to kind of to reveal the conduction block that you want to see, you can actually focus on your ulnar nerve apart from your weak nerve on examination. And many a times we use transcutaneous high voltage stimulation, not just the regular stimulating electrode that we use in the labs. We may have to use a high voltage stimulator or a magnetic stimulator to bring out this conduction block that we want to see. So it can be done, but as I said, it is not that easy. It has to be correlated. Clinically, you are quite convinced it is a motor neuropathy with conduction blocks. However, you may not be able to demonstrate your conduction blocks on neurophysiology that well. So it is very, very important that you go in those cases. You will have to go with your clinical judgment and also ask for your anti-GM1 antibodies, which could be positive in about 50% of the cases. And they do respond very well to IVIG or cyclophosphamide. And now there's a lot of evidence coming around to say that rituximab also has effect on in many cases which are resistant to IVIG. Okay, so that was multifocal motor neuropathy with conduction block. So we've seen an entrapment neuropathy, common peroneal nerve. We've seen L5 radiculopathy. We've seen HNPP. We've seen multifocal motor neuropathies with conduction block, all presenting in a very similar fashion. But it is the history, it is the diligent fashion at which you, like the protocol that you follow while trying to demonstrate what you want to see, especially in cases like the multifocal motor neuropathy, where you want to show the conduction blocks. Now, case 5 is a 55-year-old with a history of right foot drop. He has been having some low back pain on and off, otherwise very healthy, no pain. He walks with a foot drop, and there is weakness of his ankle dorsiflexion. But when you carefully examine him, there is also some weakness of his plantar flexion. His sensory examination was normal, but his reflexes are very brisk globally. And upper limb examination reveals that the left first dorsal interosseous is slightly thinned out compared to the right. Now here again, there is something that is just not focused on the leg. We are seeing something more spread out. So we want to take it step by step, right? So we start doing the nerve conduction study. We clearly show that the affected leg motor responses are smaller than the other side. So there is clear asymmetry. Then we go on to show that the sensory response is well preserved. So already you start thinking, are we dealing with a preganglionic lesion? And here, I'll show you this video. What I did not mention earlier is what we saw when we saw his muscles. Can you see the fasciculations? Okay.
We are not able to see the video, ma'am.
You're not able to see the video?
No, only the image is there. We are not able to see the video.
God, I don't know what's happening today. Okay, that was actually a muscle fasciculation. Let me play one more video and let's see whether I'm able to get it across. And here is the fasciculation potential that you demonstrate when you are when you're doing the neurophysiology electromyography. Now, my professor, and I've also worked with Professor Kerry Mills, who was instrumental in the formation of Awaji-Shima criteria for motor neuron disease. neurophysiological examination, he always said, you have to be extremely patient as a neurophysiologist, and you should have a good sense of hearing. He would even jokingly say, it's okay to be blind, but you can't lose your sense of hearing. Because when you're trying to examine the patient with electromyography, and when you put the needle in, what you want to see is the spontaneous activity. And the spontaneous activity, which includes fibrillation potentials, positive sharp waves, and then the fasciculation potentials, which was then included in the Awadi-Shima criteria, not there so much in the LS-Goriel criteria. Now, when you hear, you hear a splattering noise with fibrillation and potentials and positive sharp waves, as if water splash into oil, kind of. Whereas when you hear the fasciculation potentials, it's more like drops falling, tock, 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 tock. So I'm just praying that you're able to see this. Are you seeing? Hello, guys.
We can hear it well. We can
You're
hear
able
it
to
well.
hear it, but you're
Not,
not able to see it.
yeah.
Okay, now you've become a neurophysiologist then. You're able to hear it but not seeing it, is it?
Yeah, we can hear the sound. That's it.
No, what's going on? I don't even know how to rectify this problem.
Dr. Bhuvana, is it possible to send your video across, and can I try sharing it from my screen?
Yeah, why not? Let's do that. I'll quickly do that. Just hold on.
On Telegram would be the easiest way because that is quicker.
Okay, shall I do it now, or shall we do it after? Just show the videos after Radhika's either, because I don't want to delay her talk.
So if you can just send it to me, then let her take over. And then
Yeah, and then I'll just show the videos, then that will be good.
Sure, because
okay?
it's been quite broken because we can't see there's no flow of your PowerPoint.
Yeah, the PowerPoint is one. Mostly I'm looking at the videos. That's what I'm actually disappointed with, that I'm not able to show you.
They seem like really artistic, but we are not able to appreciate it.
Okay. Shall I now carry on, or shall we do it after Radhika's talk? What shall we do?
Dr. Sumant, your call.
Ma'am, we can carry on. I think we can finish.
Finish, and then maybe I'll just show the videos if
Yeah,
possible.
can show the
after
videos
the
in the
talk.
end.
Yeah. Okay.
I think so. That will be fine.
Okay. So we were talking about, you've heard the fasciculation potentials, right? Did you hear it?
Yes.
Okay, so that's the kind of sound you will hear when you're hearing fasciculation potential. So it goes tock, 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 as if drops are falling. Whereas when you see fibrillation potentials or positive sharp waves here on the right side, and this is a fibrillation potential, which is a negative potential, and positive sharp wave is a positive potential, of course. So, and that goes down. There's a downward deflection. And this, when you hear it, it will be more like oil splattering, that kind of sound. Further on, you can add on a little bit more when you're trying to examine a patient with motor neuron disease. For example, just as we do in single fiber EMG, you can actually lower your filter settings. So your lower pass filters, your bandwidth, you reduce it to about 500 hertz, and you actually try and identify a single or maybe a couple of motor units which will show this kind of variations. It's not exactly like the jitter. It is a jitter, but we don't call it a jitter. They actually call it a little jiggle or a block, but more like it is this. The concept here is very similar to a single fiber EMG. It's just that because in motor neuron disease, there is a lot of denervation and reinnervation happening. There is instability of the motor units. So when we are talking about a neurogenic motor unit, how do you describe it? You describe it as a fast firing, large motor unit potential, complex, polyphasic, and you see when you do the recruitment pattern, you will not see the motor units filling up your screen. So there is reduced interference pattern. This is your regular neurogenic feature that you want to see in your EMG. So you will see a fast firing, more complex motor unit potential, polyphasic, large amplitude, and the interference pattern is reduced. And when you in motor neuron disease, because of the denervation and the reinnervation that keeps happening within the muscle fibers, you are able to show an instability in these motor unit potentials. And that, to demonstrate that, you will actually change your filter settings and then show this kind of instability that adds on value when you're doing your electromyography, in addition to what you do with your standard EMG that you do for your motor neuron disease study. So this was clearly a motor neuron disease patient. And this is the, it's a very busy slide, but we are actually trying to differentiate, see the difference between an L-Escorial and an Awaji-Shima criteria. As I said, the Awaji-Shima criteria was formulated in 2008, and they actually said that please don't just look at the neurophysiology, do it with the clinical context. And also they wanted this fasciculated potentials to be included as part of the examination to show this instability. That is also considered, and also to show the motor unit instability as part of your denervation, reinnervation process that happens with motor neuron disease. So these were the extra features that were included as part of your criteria, neurophysiological criteria, to determine whether we are dealing with a motor neuron disease or not. And finally, case 6. Now this is a little bit of a twister, because this is a young boy, a 17-year-old boy. So he comes to you with weakness of both feet. Big toes, he's unable to raise. He's a tall guy. Gait was essentially normal, slight eye-stepping gait, but essentially normal. But clearly, the extensor hallucis longus muscles were weak, and it was weak on both sides. Reflexes were normal. Rest of the examination was normal. He had a spine MRI, which was normal. And again, we go back to the steps. We do the motor study. Yeah, the motor study shows that from the tibialis anterior and the EDB, the peroneal motor responses are smaller on the affected side. The sensory response is relatively spared. I mean, it is spared. So there's something that was not matching. So we thought we'll go and do the EMG. And this was the EMG from the tibialis anterior. Now here, yes, this is a complex motor unit potential. It is polyphasic. It does seem to have an reduced interference pattern, but you can see that the amplitude is a little bit smaller. And although you feel there is reduced interference pattern, but actually it didn't have the quality of a real neurogenic motor unit potential. So something was not fitting in. Yeah, we, as I said, we kind of pondered over, and it just took us some time. Then we saw that the boy's weakness was getting a little bit more pronounced, and so we thought we'll do some genetics. And the genetics clearly showed that he had GNE myopathy or Nonaka myopathy. This is a distal myopathy, and here the GNE gene is the gene that encodes enzymes UDP-N acetylglucosamine 2-epimerase and N-acetyl manosamine kinase. So they are involved in the sialic acid biosynthesis. So because of the enzymes being affected, there is hyposilization of the muscle glycans. And so the typical presentation in these young, mostly they come as young patients, and it's very rare. And they actually show this typical bilateral foot drop or bilateral big toe weakness. And yes, with age, they do progress, but there is quadriceps sparing for a very, very long time. You can have heart muscles being affected. And when you do the histopathology, there is fiber variation, atrophic fibers. And in addition, when you do the Gomery trichome staining, there is there is rimmed vacuoles, and there's no signs of inflammation. So this is the typical picture that you see from muscle biopsy. And it is, there is a lot of potential therapies that are seen along the horizon for this. There are therapies that can increase the sialization, including IVIG, which is supposed to be highly silated, containing highly silated glycoproteins. And they've also tried to use this mannosimin containing agents to increase the activity of this enzyme. And of course, in addition, there are lots of research that's happening about using both gene and cell therapy as part of the treatment. And it looks very promising in terms of treatment for this condition. So in summary, what I would like to highlight, as I started the talk with, is a very thorough examination and history taking is essential. And when you do your nerve conduction study, it's important to follow the protocol where you pay attention to your sensory responses. Your sensory responses is going to give you the first clue, whether it's postganglionic or preganglionic. If necessary, we need to do further testing like proximal stimulation. You can add on an electromyography to see whether you're seeing myopathic features or neurogenic features. And of course, once you do your neurophysiology, you can, of course, add on your ancillary tests like your muscle biopsy and genetics to further identify and localize the problem. But very important when you're doing this nerve study is history taking, examination, and following the steps of neurophysiology very, very carefully from step one, that is doing your motor study and the sensory study properly. Many a times you see in many labs, they just do one limb or just the lower limbs, just the upper limbs if the problem is concentrated on the upper limbs. But if there is doubt or ambiguity, please do all four limbs to get better idea of what you're dealing with. Thank you very much.
Thank you so much, ma'am. We'll come back to your videos after Dr. Radhika's talk.
Okay, sure.
Yeah. So now I'll invite Dr. Radhika Manohar, who's a consultant neurophysiologist at Narayana Health City, to give her talk on electrodiagnosis in SMA.
Suman, can you see my screen?
Yes, ma'am, I can.
And let me see if I can do PowerPoint. Is it? Sorry, slideshow. Can you see it as slideshow?
Yeah, I can see it as slideshow now.
Okay, all right, should we go ahead? So good evening, everyone. Thank you, Dr. Bhuvana, for that really comprehensive talk that really covered most all aspects of neurophysiology. I am actually going to do a very brief little presentation, just focusing on what we do in somebody who we suspect may have spinal muscular atrophy. We'll just quickly go through a couple of cases, bearing in mind all the principles that Dr. Bhuvana mentioned. We'll also quickly go through electrophysiological features in SMA and this technique called MUNI or motor unit number estimation, just an overview, followed by what happens to electrophysiology in different types of SMA, if there are any changes at all. And then, is there any need in doing nerve conductions in EMG when you have so much genetics available at your fingertips nowadays? So this is not the same child, but this is a baby who was a non-sitter. And you can see the sensory and motor nerve conduction studies, the data on the screen on the right. if I ask you to just focus your attention on the sensory nerve conduction studies first, you can see the median ulnar and medial plantar responses were tested, and you can see the amplitudes are pretty good. They're microvolts in microvolt sensory responses, obviously, and they're quite normal. But if you go up to the motor studies, and then you can see that the motor amplitudes are in microvolts, they're very, very small. And normally motor amplitudes are in millivolts. So there's clearly a discrepancy here where the motor responses are affected out of proportion to the sensory responses. In fact, the sensory responses aren't affected at all, while the motor responses show reduced amplitudes. And this is a bit that Dr. Bhuvna was mentioning about motor axonopathy or motor neuronopathy. So when you see an abnormality like this, where the sensory responses are normal and the motor responses are severely reduced in amplitude, then you're thinking most likely this could be a motor neuronopathy, which usually localizes to the anterior horn cell, or a motor axonopathy. A motor axonopathy on its own is a very rare condition. We don't really see it very often. So, but a motor neuronopathy or an anterior horn cell disorder, both in the adult world, I mean, particularly in the adult world, and in our sort of world where we see a lot of SMA cases, are pretty common. The normal SNAPs, or sensory nerve action potentials, reduced amplitude of the CMAPs, or compound muscle action potential. So when we did the EMG, so these are all different babies. I just want to show what it looks like when we do EMG for these little children. So deltoid and biceps and things. You can see that on the screen there's a little finding summary which says fibrillations, positive sharp waves, and then reduced interference patterns, reduced motor units, long duration, which basically means neurogenic motor units. All this indicates that these muscles are denervated, and they're actively denervating. And this little baby who's a non-sitter, so likely a type 1 or maybe type 1C, the denervation is quite significant in the limbs, but you can also see it in the paraspinal muscles, which is the thoracic mid-thoracic paraspinal muscles, as well as the tongue or the genioglossus. So what we were taught essentially is when you start in little children and you start to do your EMG in little children and you're looking most likely for SMA, you would start with the tibialis anterior, because especially little babies, infants, they're not going to follow your commands. So, but putting a needle in the tibialis anterior means that there will be a sudden ankle dorsiflexion, which will give you at least a few motor units that you can examine. So another muscle where the child will involuntarily, sort of voluntarily flex, but not to your command, is the biceps. So these are the kind of muscles we choose. As you can see, active on chronic denervation in limbs, and predominantly chronic denervation bulbar and paraspinal muscles. And this doesn't really matter. This pattern of whether you see active denervation more in the limbs or more in the proximal muscles may vary depending on different types of SMA. So the denervation pattern doesn't vary. It doesn't stick to any one type of SMA, just to let you know that. But what you are looking for is denervation, both in the limbs as well as proximally. That means in the bulbar muscles as well as the thoracic paraspinal muscle. So this is something which I'm sure you would have all seen at one time or the other, preganglionic versus postganglionic. So again, as Dr. Bhuvna mentioned before, preganglionic is where the sensory responses are preserved right here, and the motor responses are affected, and usually tells you it's either root, if it's very in a very dermatomal or myotomal pattern, or if it's anterior horn cell, if it's quite a widespread pattern. So again, just to wrap up the nerve conductions and EMG changes in SMA. So you look for, the sensory responses will be normal, and the motor amplitudes will be affected, showing a reduction in motor amplitudes, which tells you that this lesion is preganglionic. And when you start doing your EMG, you see these fibrillations of positive sharp waves. These are positive sharp waves when the muscle is at rest. And then you see these, what we call neurogenic motor units, where the motor units are long duration motor units and are recruiting at a high rate. So there's reduced recruitment, as we call it, with reduced interference patterns. But in end stage disease, you can actually see what looks possibly like a little myopathic pattern, where the motor units are very low amplitude and very sort of short duration, but the interference pattern will be reduced, as opposed to a classical myopathy where there will be a full interference pattern with early recruitment. So just to bear in mind that the chronic SMAs may look like, may look a little like myopathies, and that doesn't mean that there is a muscle involvement there. So as far as, so that was your nerve conductions in EMG. As far as neuromuscular junction abnormalities, so there was a study where they found that almost 50% of the patients where they did low frequency repetitive nerve stimulation, both in facial as well as in hands and spinal accessories. So it was different. Children had sort of different muscles that were tested. They showed that about 50% of them showed a reduction in the amplitude. So there was a decrement, which was more than 10%. So they concluded that this was possibly suggestive of a neuromuscular junction disorder. And they said that 2 out of 4 patients with type 3 who tried predostigmine reported a reduction in their fatigue. But to be honest, we see this kind of pattern both in the ALS cohort as well as the myopathies, muscular dystrophies. So it's more likely that these changes that we see is because of denervation and reinnervation leading to nascent neuromuscular junctions, resulting in this kind of repetitive, this kind of decremental response on low frequency RNS. On high frequency RNS, there is no change, there is no increment at all. So this is another child, a little older. Again, you can see the sensory responses are completely normal, 56 median ulnar, 38 microvolts. But when you look at the motor responses, they are reduced, so very similar to what we saw before. You could argue that these motor amplitudes are slightly better than the previous child's, but to be honest, there is no real major difference in the denervation between these different types of SMA. When it comes to the motor amplitudes in different types of SMA, there may be a difference, and we'll talk about that in a minute. So again, the same child EMG was done. So this is a type A as a SMA type 2. And there you can see that the denervation is not, active denervation is not significant in the limbs, although chronic denervation is very significant. And there's more active denervation in the thoracic paraspinals. You don't see much active denervation in the genioglossus. And the reason is not because it's not there. It's because it's very difficult to get a child to relax his or her tongue while the needle is in a usually submandibular approach, but it's still there. And it's more the lack of, my inability to elicit the fibs and positive shock waves rather than they not being there. So again, normal sensory responses, reduced amplitude motor responses, widespread active on chronic denervation, as you can see there, indicating a diffuse anterior horn disorder. This will be how our report goes out, regardless of whether it's an adult or a child. Obviously, in this context, we will raise a possibility that this could be a spinal muscular atrophy. So this is how we do the thoracic paraspinals, just a picture there of another child. Quickly say a few words about motor unit number estimations. I need to put my hands up here. I'm trying to figure this out myself. So we started doing Muni in our lab, but I'm really trying to learn as I go. So basically, it's part of the electrophysiological methods that we have to look at motor neuron degeneration or motor axon degeneration. It tries to estimate the number of motor units in a muscle. So it's not an exact number, it's just an estimate. And obviously, it helps, like I mentioned, in conditions such as ALS and SMA. It helps in diagnosing not so much, because you can make a diagnosis with the clinical and your nerve conductions and EMG. But the monitoring the progression of the disease and any response to therapy is probably something that Muni can provide. So it's a little bit more of a quantitative assessment. And this is the original Muni that McComas described in 1970s. Where he did an incremental method of trying to obtain the single motor unit potential. So I'll just explain very briefly. So the technique is, so the first, there are 2 steps really to Muni estimation. The first step is you get your CMAP. You decide which nerve you're going for. Ideally, you go for a nerve where the amplitude is reasonable, it's present, not a nerve where the amplitude from the muscle is in microvolts. And then you give a supramaximal stimulation, as you would do with any motor nerve conduction study, and you get your CMAP response, like a median recording from abductor pollicis brevis, as you can see on the screen. Then you get your median CMAP. Once that is done, the next step is the estimation of what they call the single motor unit potential, the mean of, so you have to basically record multiple single motor unit potentials, and the algorithm will then give you a mean SMUP, or mean single motor unit potential. The calculation of Muni is a CMAP, a supramaximal CMAP amplitude divided by the mean single motor unit potential. And it's Muni doesn't, it doesn't really have a unit following it usually, so it's a number. So there are different methods that you can use. The incremental method is what I have in my machine here, and what we are trying to use here. There is another method, again more used, called the multi-point stimulation, and the spike triggered averaging. I've never done that. I don't know how to do that one. So in this incremental stimulation methods, you can see that there are these multiple motor responses that are recorded. So each is at a sort of small increment to increment. So you start increasing your current very from a low to a high in a very gentle, sort of very 1 milliamp or 2 milliamp increments to try and get your responses. And once you get the responses, that is then averaged. Again, all that is part of the algorithm, and the machine does it. You get averaged, and then you get a single motor unit potential, and then you get your maximum CMAP, sorry. And then they divide the maximum CMAP by the mean single motor unit potential, and that's what gives you your Muni. So the one issue we have is, obviously this is such a rough, it's just a surface stimulation. This is when you do a surface stimulation and you see a response where the morphology looks a little different, then it's very possible that maybe you are actually stimulating another set of motor units, not the original one. So it's really subject to a lot of variability, operator variability. So reliability is an issue. So that's a bit of a problem. Again, this is another type of method to acquire the single motor unit potential, which is a multi-point stimulation. So you basically stimulate along the length of the nerve. That's the median nerve there. So you just stimulate along the length of the nerve. I haven't used this method. I don't have that in my machine either. And you look for these all or none responses. And then again, the machine will do the calculation for you for the Muni. So those are all what we do, what we call a manual Muni. So that's what we do, with our hands, and we stimulate and go on like that. But there are these two new methods, Munics, by Dr. Nandedkar's group, and the M-Scan Fit by Dr. Bostock's group. So these are all softwares. This is basically, you just need to get a couple of motor responses from the nerves, and then the machine does the rest of it. So this is much more reliable. It's been validated, and this is really ideally the way we should be doing a Muni moving forwards, I think. So where do we stand with all these electrophysiological measures as regards treatment? So you can see here, they do these kind of a Muni and the CMAP responses before and after nusinersen. And they found that there was an improvement in the CMAP, maximum CMAP. There was an improvement in Muni. So they appeared, both the maximum CMAP values as well as Muni appeared to be something that we can use, objective measures that we can use to try and track our treatment. So what happens with all the different types of SMA? Is there any change in this electrophysiological things that you do? So denervations, the EMG part of it, there really isn't that much of a difference. There aren't any studies looking into that, and there aren't any good studies looking into that in detail either. So basically, there was a study. This is the one that's most quoted most often, and it looked at Muni values as well as maximum CMAP values of multiple nerves. In groups of patients who were SMA1, type 2 or type 3. And they found that the change in Muni values, so they were regularly checking the Muni values every 6 months to 1 year. And the change in Muni values was equal in all three types. So the untreated patients, the Muni kept reducing throughout, and that was seen in 1, 2, and 3. While the CMAP value change was much more severe in SMA2. P is not that impressive, but SMA2, the CMAP value, the change in CMAP value, or the reduction in CMAP value was more severe in that particular group of patients. But actually, the one thing that really made the maximum difference in Muni and the maximum CMAP value was age. Age was independent, and it was the same in both SMA1 and 2. Also, SMN2 copy numbers, and if it's less than 3, they correlate with lower Muni and lower maximum CMAP values, which is something which we know, sort of instinctively we know that clinically lower SMN2 copy numbers will be a problem. And the same way with lower functional scores, and same way Muni is also low and maximum CMAP values are also low. And as we know, again, maximum CMAP values correlated best. So rather than MUNI, the maximum CMAP values correlated best with the functional outcomes. So just my final slide here. So what is the role of electrodiagnosis in SMA? So most patients, you have your genetics, you have your clinical presentation, you have your genetics, and then you have your answer. But very rarely, atypical clinical presentation, that's when you can, you may end up doing, as a neurophysiologist, doing electrophysiological tests, especially nerve conductions and EMG in patients with suspected SMA, non-5q related SMA, or adult onset cases. So SMA3s, where patients, adolescents or young adults present in OPD with proximal limb weakness, which could be part of a muscle issue as well, or a muscular dystrophy. So that's where electrodiagnosis may come in handy. Obviously, things like maximum CMAP values and MUNIs, all that is still very much part of research, but that can be used both to look for objective markers of improvement and correlating with functional outcomes with treatment and without treatment. Thank you. Any questions from everyone? Anyone?
Yeah, thank you, ma'am. Thank you for that presentation. Yeah, if anybody has questions, they can type it in the chat box. We'll let the speakers know. Dr. Anne, do we have the videos? Can you?
No, she was unable to send it.
Oh, okay. Okay.
I think because the videos, we were not able to transport it on the email. That's the problem. Because it's on my, it says that the sharing part, I don't know what went wrong. It was not moving. Were you able to see the slides otherwise?
Yes, ma'am. We were able to see the images and the slides were fine.
Only the videos were not able. Yeah.
Yeah, the videos we could hear the sound. It's just that it was not moving.
But the slides you could see, right?
Yeah, the slides we could see.
Okay. Sorry about that. It's just such a shame, actually.
We can't share it on WhatsApp and then download it.
Yeah, most of us use WhatsApp or things because we do lots of talks, and that's the easiest way of transferring. Telegram for larger talks and WhatsApp for smaller talks. Anything under 25 MB is WhatsApp. Anything above 25 MB up to 1 or 2 GB is Telegram.
Telegram.
Yeah.
So those videos are really nice. Bonus. It would have been helpful, I think, for the residents. But
yeah, actually, if you play the sounds were very typical as well.
There's a question, I think, in the chat box, isn't it? From
I think. Yeah, this is for you, Radhika ma'am.
Yeah. Which explains SMA if children follow up on incidents, is there any improvements in math? So I don't know yet. That's what Dr. Anne and I are trying to figure out now. So I was trying to figure out MUNI for some time. And then there were lots of issues with the machines and this back and forth and all that. So MUNI, we can do it. I still would prefer to have the Munix. Sanjeev Nanditkar's Munix is a really good program, very easy to do and very easy to do in little babies. So the answer to your question is, I don't know yet. I'm hoping I'll be able to answer that in a few months, maybe a year's time. But right now we are testing, we are doing baseline Munis and maximum CMAPs, and then doing it after as well.
I think Radhika, Dr. Matthew Pitt at Great Ormond Street was trying to do this Muni to understand the response to treatment as well as he was doing the study. Again, it will be interesting to know what the outcome was. So maybe you can get in touch with him as well to understand this better.
Because I'm not entirely happy with doing the Muni manually, because I would much rather have a good program, software program like Sanjeev's. That would be the best one. So that's something I'm going to look towards getting really. That would be much more reliable, I think. Easy to do, so easy to do. He was demonstrating it. So easy.
I have a question. I'm Dr. Sitaram. I do research in basic sciences. My expertise is in lipidomics. So actually in lipids, we have ionic lipids like phosphatidylcholine and phosphatidylethanolamines. So these lipids carry charge. So since you do this EMG and record the charge transfer, is it give any result if we study lipids from plasma? Is plasma a good sample, or we should study a nerve sample? What do you think?
I think I may not have understood the question, but when we do nerve conductions in EMG, we do on nerves actually. So soft tissue, through soft tissue, we stimulate and then record nerves. And then for EMG, we place the electrodes within the muscle. So we wouldn't, we wouldn't really be.
It's
Isn't
more
it?
the electrical activity that we are looking at. So whether the lipids play a role here, we're not sure. So I think it's more the way the
it is reported in the lipids in the nerve play a very important role. That is reported, but sampling is the problem. Getting a sample from the nerves is a problem.
Yes, yes, I'm sure that's correct actually. Yes.
But would it reflect in plasma in any way? No. Hard to tell. Okay.
Yeah, Dr. Bhuvaneshwar, I think, ma'am, you have a question by Dr. Aditya.
Okay.
He wanted to know, we see sometimes this progressive post-polio syndrome, which can be a differential for ALS in adults. So he wants to know if there are any electrophysiological features which can differentiate between the two.
Post-polio syndrome, basically it's as a patient who has been stable for a very, very long time and then starts to show signs of deterioration, progressive muscle weakness in areas which were not previously involved, and there's a lot of pain involved as well. For some reason in post-polio syndrome, although this is more an anterior horn cell disorder, there's a lot of pain involved clinically. That's what you see. When you do the electrophysiology, actually you do not see much of fasciculation motor units, or you may see fibrillation potentials and positive sharp waves, but you may not see fasciculation potentials in these patients. And secondly, the history, whether you're able to exactly differentiate. I think the more the history, like how I started off saying, just the neurophysiology will not be able to clinch the diagnosis for you. You need to look at the neurophysiological evidence in the clinical context, along with the history, to understand what we're dealing with. So because if you just give me a muscle with some positive sharp waves and fibrillation potentials, muscle wasting, motor units which look neurogenic, I'm by just looking at that, we may be fooled by saying it could be ALS as well. But a history in this scenario will only help us differentiate, but just neurophysiology will not be able to do that differentiation.
Thank you, ma'am. Any more questions? You can type it into the chat box. Okay, then I think if there are no more questions, then Dr. Ann, can we close?
Yeah, thank you so much to our speakers, and thank you so much, Dr. Sumant, for sticking to time. Dr. Radhika and Dr. Bhuvan.
That is Dr. Radhika and Bhuvanas. I think we'll thank them.
So, until we meet next time.
Yeah. Thank you so much.
Everyone, take care. Bye.
Bye.
Bye-bye.
Thanks. Bye.